Uh, Good evening, everybody. Today, our topic is RIRS with suction. As you all know, before officially any device is made across the world, Dr. Parimal Gharia, who is the speaker, has made his own innovation where how you can use suction in RIRS. He will tell detail about that, need of that, and usefulness in the large volume stones. To be honest, whenever there is a controversy between the powder and fragments, recently we have seen from Panipat, Senior Surgeon Gupta sir, he says that I will make fragments and remove all the fragments. On the other way around, Kandarp Sarik sir and myself, some of the who are followers of the Oliver Traxler, we do powder and we feel that next day all the powder will come out. We did not face much problem. So we are in between this. We feel that if you remove the scope outside every time, in and out, ureter may be damaged and fragments may stuck in the ureter, we are worried. Whereas if a lot of powder is there in large volume, we are worried that it may conglomerate and make a stone-like picture, and ultrasound or CT may show it like a stone. And it may form fluffs also with the. So whenever you suck all those things, it is definitely better. The future is small size ureteroscope with suction. So Dr. Parimal Gharia, I will introduce first and then I will ask him a few of the questions. Let me share the screen of his details. So today's session is suction in RIRS. Dr. Parimal actually a few years back has become close to me, and in no time he quickly understood the importance of the academics and is very active. When I am reading his career, he is also a good academician, and he is from the Surat, and he has his own hospital, Icon Hospital in Surat. He has completed his medical school from BJ Medical College, as everybody knows is one of the reputed medical colleges. MS General Surgery from NHL Municipal Medical College, Ahmedabad, again Ahmedabad. He has worked as assistant professor of New Civil Hospital, Surat in 2006-07. DNB, again, very well-known Institute of Kidney Diseases and Research Center, where a lot of stone work and transplant work happen, which he did in 2011 when the institute is at the peak, worked there as assistant professor till 2012. Endourology and laparoscopy naturally will be the areas of interest, whoever has done from IKD. He's expert RIRS surgeon now. He quickly picked up and making his own videos and expert comments in Twitter repeatedly and appreciated by many people. He's proponent of suction in RIRS. He has developed a simple and cost-effective way of using 10 centimeter and 100 centimeter extension with three-way and suction ureteral access sheath. We are also using some of the companies under the trial. We cannot disclose, but Parimal was using way before these things happened across the world. Is actively participating in academic activities at journal and national level, have strong social media presence, especially in the Twitter. All academic, I mean to say. So with this, I will stop sharing. Parimal, hi. So thank you for accepting the invitation and coming to the stage. In last 5 years, I have seen a lot of enthusiasm with you, a lot of discussions you participated. Your work has increased and your experience in stones increased. And recently, you have started a good WhatsApp forum, Euromentarium, where all of us are learning about the instruments. It's a great initiative. I must tell it will remain for a long time. Very good discussion, nothing nonsense in that group. Those urologists who are close to Parimal, ask him permission, because now WhatsApp has how much maximum number, Parimal?
It's 1,000, sir.
1,000. So you can join so that more juniors will be beneficiaries. And
Okay.
with these words, I will hand over the program to you. Great.
Okay. Thank you, sir. Thank you, Dr. Chandramohan, sir, for inviting me. First of all, I thank you because I have been to Preeti Urology Hospital for 3 times in last 5 years and spent almost 2 full days at Preeti Urology Hospital and learn a lot of things. When the Preeti Urology has only one branch, at that time I visited, and at that time my RIRS numbers was very less, but I learned a lot of things from Preeti Urology Hospital, and specifically the recording the systems and the keeping the records of the surgeries. That was I learned from you, sir. Thank you, sir.
Thank you.
I will start.
Yeah, please.
So all of we know that the urolithiasis burden has increased all over the world, and the prevalence is specifically is increased in Asia. And secondly, the urolithiasis is a recurrent disease. So the patients who are already forming stones will be making new stone again and again. So the recent trend in urolithiasis management is, you can see, is that the ESWL is going down and the RIRS is picking up. The PCNL rate has remained all over the world the same. But with the increasing number of RIRS, the infection rate has increased from 4.7 to almost 6.0. And with this infections rate, the ICU care is required and inpatient care is required. So the overall, the sepsis has remained one of the Achilles heel for the RIRS. What is the cause of this sepsis? There is a normal backflow system in the PC system and the kidney, which have a pylolymphatic, pylosinus, pylovenous. All are the backflows are there, and this will be activated according to the intrarenal pressure. So whenever there is a rise in intrarenal pressures, this backflow mechanism action. So if there is an infection from the stone or already presence of infection in the PC system, or we introduce from iatrogenic infection, then with the high pressure and this infection will load the whole circulatory system with the endotoxins, and patient may go into sepsis and septicemia. Second problem, the recently we are discussing, lot of discussion is going on, is the intrarenal temperature. Because whenever you fire a laser, there will increase in the temperature. There is a but the intrarenal temperature depends on the irrigation fluid. So at the 40 ml, there was no injurious temperature was found in the kidney. Second problem with the large stone is, when you start doing dusting the stones, there are a lot of snowstorms. You can see in the video, there is a very good vision, but as soon as you start glazing, there is a snowstorm or a snow globe effect, and then you require to pedal it down, or you can show that pedal on, pedal off mechanism, so that the dust settles and you get a good vision. So second thing is the large fragments hiding behind. At the end of a large stones, if you are doing an RIRS and if you are doing a large stones, at the end of the procedure, there are a lot of fragments or a lot of dust in the PC system. And this dust will block the vision, and it will also block, difficult to visualize the small residual stones lying inside this. You require additional accessories like baskets or tilting the table, or you can repeat surgeries, and ultimately there are some fragments that will remain in the PC system. So there are always a concern about the residual fragments or residual dust in PC system. So ultimately it's a poor vision, high intrarenal pressure, and higher intrarenal temperature. All are related to the irrigation. So rather than to be more precise, it's inflow and outflow that will decide the vision, the intrarenal temperature, intrarenal pressure, and everything. So if there is a good outflow, it will have a vision like a continuous flow resectoscope, and good vision is maintained throughout the procedures. So possible solution of these are, you can decrease the irrigation, but by decreasing the irrigation, you may decrease the intrarenal pressure, but the vision also goes. Increase in irrigation. When you increase the irrigation, the vision gets better, but there is a rise in intrarenal pressure. So the solution is to increase the outflow. Outflowing increase improves the vision, decrease the intrarenal pressure and temperature, and improves the inflow. When there is a good outflow, the inflow also improves. So what is the solution? Solution is the suction in RIRS. Increase the outflow. The concept is to increase the outflow. So there are different techniques described for using a suction in RIRS. Suction outside the scope and suction through the scope. Suction outside the scope requires like suction ureteral access sheath, which is bendable or non-bendable, or some special devices like Calera or KVAC system. Now, another system is the suction through the scope, the suction with the special devices, or the suction without special devices, like what we call is a manual intrascope suction technique. What we follow is a MIST. So these are the suction access sheaths. The suction access sheath allows continuous flow of a irrigant from the scope to the outside system. Whenever we do not use a suction ureteral access sheath, the ureter get to collapse around the scope, and there is decrease in outflow and decrease in the vision. So whenever you use a suction access sheath, there is an increase in outflow and that will improve the vision, and that will increase the irrigation flow. So these are the suction ureteral access sheath. You can see these are the access sheath with the oblique, almost a 45-degree angle. A suction is attached. A suction is attached to a bottle, and the bottle is attached to a routine suction or a low pressure suction devices. So these are the assembly for the suction ureteral access sheath. How to use a suction access sheath? Once your access sheath is introduced, a suction is attached to the suction bottle, and that suction bottle is attached to an outside suction, that is a low pressure suction. Whenever you want to continue the suction, you need to convert the knob, and there is one knob is there that it will increase, it will activate it when you want to activate the suction. If you open it, the suction will not be affected at the tip of the suction access sheath. You can see this is a large upper ureteric or a uretero-pelvic junction stones, and there is no flow is going across the stone because of an impacted stones. So in this case, we have used a suction ureteral access sheath, and you can see there is a continuous flow of an irrigant is maintained and the vision is maintained. The surgeon is doing continuous lasing of the stones, and the stone fragments are eventually coming out. So by suction access sheath, you can improve the vision and you can continue the laser firing till the time you want it.
Yeah.
So how to use a suction sheath? Whenever we use a suction ureteral access sheath, the suction access sheath sits below the pelvis in the upper part of the ureter. So if you apply a suction from when the scope is outside into suction access sheath, the upper ureter above the tip of the ureteral access sheath gets to collapse, and there is no effect at the tip or the pelvic access system, and the fragments did not come out. So you need to keep your ureteral access sheath below the uretero-pelvic junction, and you can use the scope inside the pelvic access system so that the irrigation flow is maintained from the pelvis to the ureter and through the outs.
Okay.
You should keep the pressure as low as possible, -100 to 150. The advantage of suction ureteral access sheath is there is a continuous suction is going on, so there is a continuous improved vision. It can increase decrease the intrarenal pressure, decrease the operative time, and sometimes you can use a Venturi effect or a vacuum cleaner effect. When the multiple fragments are on the ureter, you can withdraw your ureteroscope up to till the tip of the access sheath, and the fragments will get sucked into this. This is better suited for TFL users because there is a lot of dust is making. What we have previously discussed, the dust particles or the snowstorm effect will be decreased by this suction ureteral access sheath. The disadvantage of suction ureteral access sheath is still you need to put an access sheath, and it is for uncontrolled suction or an excessive suction may cause a mucosal bleeding because of too much negative pressure inside the pelvic access system. Second thing, you are keeping the ureteral access sheath tip at the upper ureter, and you need to flush the fragments from the PC system or the calyx to get into suck. They have to come to the pelvis and then they get stuck. Then machine is required, and you require some trained staff to do continuous suction on and off. So for a better use, the suction access sheath required is 11-13. So 10 French section sheath, there is a very little space around between the scope and the suction access sheath. The fragments will be very less, or a very small fragments only will be sucked. It can be useful in upper ureteric stone, renal pelvic stone, large kidneys, hydronephrotic kidneys, where the fragments retrieval is always a problem, and we are not sure that the fragments will come out on its own. These are the studies for a suction ureteral access sheaths. Now, what has happened with the suction ureteral access sheath is we are not reaching to the stone or where the fragmentation is happening. So there is a modification of suction access sheath, and there was a bendable suction ureteral sheath. You can see that the wired area is a bendable access sheath. The sheath can be bent. So the suction access sheath that is made bendable, it's reach up to the calyx, and the fragments can be dusted, and at the same time it can be retrieved. So in this case, we have used a large hydronephrotic kidney and large stones. We have done a ureteral bendable sheath, and all the fragments were sucked. Like you can see, this fragmentation is happening, and the suction is also happening at the same time in this case.
Yeah. Is this sheath available in India?
Yeah, it is available in India. It is actually not made in India, but it is available in India. This is a bendable sheath. In bendable sheath, what you can do is you can reach up to the calyx and remove the stone like this, use a Venturi effect or a suction effect in that case. So the fragments can come out and you can remove it.
Very nice.
But the concern about with suction access sheath and the bendable access sheath is you are crossing the uretropelvic junction. The standard teaching in RIRS was that you need not to cross the uretropelvic junction because uretropelvic junction is the most important area for a ischemia to occur. So whenever you use a bendable access sheath, you have to cross the uretropelvic junction, and the long procedure with ureteral access sheath or a bendable access sheath across the UPJ may lead to ischemia and a problem. And second thing, with the Indian ureter, almost 33% patient will not admit 11-13 French sheath at the plus space. So whenever you want to use a suction or suction ureteral access sheath or a bendable access sheath, you need to pre-stand the patient, which is what we are not practicing routinely. 90% of our RIRS are the primary RIRS. So the maximum access sheath what we introduce is a 10-12. So it is better. It is once the whole concept of suction is lost when you put a you cannot put a ureteral access sheath into the system. So what are second thing? There are some fluoro-guided devices and suction ways introduced, but they did not pick up into the market. So how can this suction can be very effective? If the suction can reach to the dust-bearing calyx and remove under the vision, then only this suction can be effective. It should be simple, sterile, cost-effective, easily available, and the technique should be reproducible. It should not be very complicated system where you need to let a lot of training and lot of discussion before you start doing suction. So then the concept of the intrascope suction was devised. When you use a flexible scope as a conduit for aspiration, under direct visualization, the flexible scope is used, and the channel of the flexible scope is used for aspiration or a suction. The important part of this intrascope suction is a single channel, which is for irrigation, is used for the suction. So it is always an alternate. You cannot do a suction and irrigation simultaneously. So if you want to do a continuous suction, it is not possible in any intrascope suction. You have to do alternate, either do a irrigation and the aspiration. This is the first device described by Dr. Vinit Gohar sir, which is direct in scope suction. This technique they have used a multiple three-way channels, and it was attached to a suction machine, and the continuous suction was used. They have published this in a journal, and the results were equally effective as a suction ureteral access sheath. But the suction through the scope was experimented before also, and in this experiment, there were 4 times more clogging of the fragments into the channel of the sheath, channel of the scope. So whenever you use a scope as a suction device or a channel of the scope for a suction device, there are chances that the fragments get clogged up in this. So second thing is the possibility of this is there are renal pelvis capacity is 10 to 15 ml. So when you continuously aspirate it, there are chances that negative pressure becomes in the pelvic area system, and your fragmentation or retrieval becomes difficult. These were the assembly before starting a suction we were using. The intermittent suction was used, and intermittent irrigation was used and attached to a three-way system. So what we think is we just added a 10 centimeter extension tube to a already existing system, and it was attached to a 10 centimeter syringe. The concept of 10 centimeter syringe comes from the renal pelvis capacity. Pelvic area system has a capacity of 10 to 15 ml. So whenever you do a suction, maximum suction you can apply to the pelvic area system is 10 ml. Second thing is 20 cc syringe is attached to this system, and it can be used as an active irrigation whenever extra irrigation is required. You can see in this video that the assistant is doing is just change of the three-way, and an assistant is doing a suction from the scope. It is very near to the scope, so all the fragments which are coming from the scopes are directly get into this system. Whenever the assistant empties this system, at that time he continues the irrigation. Just turn around the three-way knob, the irrigation continues, and by the time he empties the 10 cc syringe, there is pelvic LSS system is again full of the fluid, so it can be aspirable again. This can be done continuously while doing the fragmentation or a dusting, so that the vision continuously becomes same.
I want to ask, the suction, while suction is happening, flow will not be there, no?
No, sir. That is a intrascope suction is only concept of intrascope suction is you can do alternate, because you have a single channel that will act as a suction conduit as well as the irrigation conduit. So whenever there is a suction, there will no irrigation.
Correct. Yeah.
Okay.
So you kept a three-way knob in between.
Yes,
so
sir.
it will aspirate from the PCS, and the three-way knob will be rotated and water will go immediately.
Yes, sir. Yes, sir.
Assistant is very intelligent. They can change immediately, and you will understand that at that time of aspiration, you stop lasing, and quickly again you start lasing. If you do every 5 minutes like this, hardly any powder will accumulate in PCS.
Yes, sir.
Very good.
You can see there is a active suction is going on. There is a very large stone in the renal pelvis, and there are multiple fragments. Now what is happening is, you can see there are the multiple fragments in the heap of this dust. There are large fragments. These fragments need to be fragmented or dusted before we can conclude this RIRS procedure. So what is happening is, the assistant is doing suction. So suction, all the small dust will be suctioned, and there will be a clear vision after some time. So it's an alternate procedure. You can see, the advantage of this system is, your scope is already in the pelvic LSS system. You can go to the pelvic LSS system, reach to the stone bearing calyces, and aspirate the dust, whatever dust is accumulated. So your vision gets improved, and the stone fragments which are not visible few seconds back are now visible.
Yeah, slowly the fragments are remaining.
Yes, sir.
Dust is getting into the scope.
For a large stones, it's very helpful, because at the end of the large dusting for a large stone, there are multiple fragments still remaining. You can see the vision has cleared significantly.
Correct.
And you can now start lasing again.
Yeah.
So this I tweeted on 14th of November 2022, and recently got a mention by Catalina Solano and Dr. Oliver Traxler's review article about the suction techniques in RIRS.
Very nice.
You can see this is a large upper calyceal stone. As soon as we start fragmenting, there is a lot of dust and later snowstorm is there. The assistant starts suctioning, so that all the dust is coming out, and your vision gets improved every time. So you can see that this is the suction aspiration is alternatively continuously doing. So the assistant is doing suction alternatively with the irrigation, so that you can continue firing the laser. So overall, your operation OT time or endoscopy time decreases with this.
Yeah. So clear it is now.
Yes, it is now. You can see at the end of the procedure, almost at the half stage, almost all the calyces are clear, except the few small fragments are remaining, which are then pop dusted. And with the pop dusting, a lot of small fragments occurs, that is continuously suction. So there is the heat produced by the continuous popcorning. Also, the heated fluid also comes out immediately. So there is no rise in intrarenal pressure as well as intrarenal temperature.
Correct.
So you can see almost at the end of the procedure, there are very small fragments, and there are a lot of dust in the pelvic LSS system. This all dust will be suctioned at the end of the procedure. So there you are not worried about making a coagulum or a small stones from out of this.
Yeah.
Second thing is, the aspirated dust can be analyzed. So all patients undergoing RIRS the dust is suctioned and dust is sent for a stone analysis. We already discussed the 10 cc syringe. The problem of the stone impacts in the pieces in the channel of the scope. The suction is done with the fiber in situ. Always do suction with the fiber in situ, so that the fragments do not catch up into the channel of the scope, and your scope is not damaged. Keep the tip of the ureteroscope hanging So it catches only the floating particles. Don't poke your scope into the dust so that the larger fragments do not get sucked in. And stop as soon as the large fragment is stuck at the tip, so that the fragments does not go into the channel and damage your scopes. There are predefined criteria for the dust also, that the dust is stone particles less than 250 microns, which can be aspirated through the channel of the scopes. How to prevent a mucosal bleeding? Don't let the PC system collapse. The assistant should understand that the pelvic LSA system is collapsing, or a surgeon should understand and stop the as soon as the PC system looks collapsing. Advantage is simple, sterile, cost effective, and it is done from the readily equipment available from the OR. There is no extraordinary equipment or a device is required. It's a controlled suction and it can be stopped easily. Advantage is it can be used with or without ureteral access sheath. Useful in the tight ureter and the primary RIRS, where your scopes is only a conduit which can remove the fragments. Can reach to a difficult calysis, and dust can be suctioned with the direct under vision. Specifically useful for a lower callosal dust and the callosal diverticulums. Advantage is it decreases the intrarenal pressure by active suction. It decreases the intrarenal temperature by removing the heated fluid. Allows continuous fire laser. Decreases the number of stages required for RIRS, and sometimes a small stones on table clearance is required, so that no post-op imaging is required in some of the cases. The limitation is it's done manually, so require a good experienced assistant. And channel clogging leading to scope damage or a replacement is a real issue that need to be tackled. Sometimes we use both the system. We use a suction ureteral access sheath and the manual suction from the scopes, both the systems. So it's when we put a suction access sheath as well as the intra scopes suction. So for the large stone, it will be helpful. Thank you.
So very good. You have explored all the options of suction. Now let us discuss a little bit of the logistics.
Yes.
Now, if you wanted to do suction through the access sheath, it should be bigger.
Yes.
At the same time, if you want to aspirate through the flexible scope also, it should be bigger. So one side we are going towards miniaturization. Other side we wanted to do suction of the dust. So in large stones, what is your opinion? Do you put a stent and put 10 by 12 or 11 by 13 sheet with good suction facility and do for 1 hour and finish all these stone, especially with TFL, and give the good result? Or first time directly you will do half and next time you will do half? You understand my question?
Yes, sir.
Stenting before large stone volume to give better stone-free rate, because PCL surgeon will argue every time.
Yes.
PCL surgeon says that in 5 minutes I will remove the stone. No need to put a stent. I will put a nephrostomy and a ureteric catheter. I will remove it one-time procedure. So how we will defend in the future those who like to do large volume stone in RIRS? So what is your practice in large volume stone, honestly?
Sir, we are doing a primary RIS in all the cases where the access sheath can be accessed.
Yes.
Even if the access sheath is not, even a 10-12 access sheath is not going, and the bare ureter scope can be negotiated in the pelvic LSA system, we practice of doing an RIRS primarily. So in that cases, when the ureter is tight or there is a outflow is an issue, this manual intrascope suction or what we devices we have made or arrangement we have made is very useful in that cases. In that cases, we will go and finish up the case, as it may take a few minutes more than the because of an outflow issue, but it can be done in a large volume stone also in the primary RIRS. And secondly, for all the patients who have been previously stented because of some reasons like infections or rising creatinine or other indications, where you can do a primary, you can insert a 10, 12 or 11, 13 ureteral access sheath and do suction ureteral access sheath as well as the intrascope suction devices.
Okay. So the suction of the ureteral access sheath is available with minimum size 11 by 13 or
10 by 12. 10 by 12 is available. But with 10 by 12,
is officially company selling?
What, sir?
Officially company is selling that access sheath?
Yes, sir. It is officially available and it is 10 12 sheath has available. So
Which company is selling? Which company is that?
Sir, India, it is sir made by valid. It is made Clear Petra access sheath, and it is marketed in India by the Aster from South India.
Aster. Hello. Hello. This is the important thing I wanted to ask because audience wants to know. Which company?
Aster, sir. Aster.
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 Okay. And they also provide the suction box, everything?
Yes, sir. Suction bottle is provided with the suction access sheath.
Very good. So, and what is the large size they are providing? Small size and large size, both they have 10 by 12 and only
10 by 12 and it's almost a 12 by 14.
12 by 14. Okay.
Yes.
When you have seen both with syringe, imagine, do you think that 3.4 French lumen size with and without 200 microns laser fiber, what is your comment on the ability to suck the small powder? See, thulium fiber laser at the end produces small dust. Repeatedly, if you suck, it can come even if the presence of, you have added a slide, even in the presence of 200 micron laser fiber, it
Yes,
can suck some amount of the, is it true?
Yes, sir. It can, the fragments you can remove, the small dust particles you can remove with the the laser fiber in the, because the 3.4 French channel will ultimately end up with the 1.1 mm diameter and 200 micron. 200 micron diameter fiber still will left with the around about 8 micron
800 microns
0.8 millimeter. So you can remove the small particles from that. So, and the idea is
length of the scope is around 70 centimeters. So when you are sucking water column,
yes, sir,
may break with the small fragments inside the lumen of this sheath, and you may not be able to suck. And again, if you flush back, they will go back into PCS. I hope you are understanding.
Yes,
some
sir.
amount of dust will suck, and they will be in the lot amount will be in a 70 centimeter tube. And when you flush back, all will go back again. So if you suck out of 100, 30, and 15 may go back again into the, any comment on that? I mean, large volume of the powder, if you want to suck in short time, sometimes it's frustrating because as you said, mucosal bleeding may happen. Assistant should understand that the mucosal collapse is happening. Quickly he has to put water, quickly he has to suck. It should be, I feel urologist can do, understand very well than technician. So it should be a very coordinated activity. Otherwise, some amount of the vision loss may be there in these type of things. I also tried this, but not very effectively. What is your comment?
What is happening is, sir, when we suck with the 10 cc syringe, you have to withdraw the scope where the capacity of the pelvis is there. If you are suctioning from the calyx, you need to come out of that calyx. You can withdraw the scope for 1 or 2 centimeters. The scope will come into pelvic access system. This will add to few ml of fluid from the lower calyx or a middle calyx. That can help you to suck the more fragments going back and forth. Okay. So you need to come out slightly wherever you are, or you may go in. If you are very at the end of the pelvis, you can go in and do a suction at that time. So you may have the idea of suction is to decrease the intrarenal pressure and improves the vision. We may or we may not remove the whole dust at the time of the surgery, but that should not be a small, reasonable amount of residual fragments should not be left in the pelvic access system, which may not pass on from the PC system, and you require a re-surgery or a RIRS again and again.
And one more thing, what I do generally is I will do the RIRS completely, and I will change the access sheath to 35 centimeters or 45 centimeters. I'll place in the pelvis. I'll put the scope, and constantly I'll be removing it by whirlpool effect, like in PCNL. If you do for, I don't take out the scope. If you do for 10-20 times with continuous water suction coming out, a lot of fragments will come out, and a lot of powder also comes out. So far, I am enjoying this only, not suction, honestly speaking.
Okay.
And if any wide ureter is present, even if you keep the access sheath in the mid ureter, all the powder nicely will come out with back and front movements of the scope. As of now, I am doing this. Definitely, the one which is most attractive is the flexible tip access sheath. What is your experience personally? It is good?
So the problem with the bendable or what called malleable ureteral access sheath is you need to keep it across the ureteropelvic junction. Second thing is the force required. The force required to bend that access sheath is to be generated from the scope. So there is a lot of strain at the end of the pulling mechanism of the your scope.
Correct.
So even with the best of efforts, sometimes you cannot bend it to lower calyx. I have tried it multiple times. Every time I did not get to the desired calyx. So the idea of ureteral bendable access sheath I have put down, and I have now come to stick to the things that is very simple. Because what happens is even if your bare ureter scope is used, you can do a suction from that scope and improves the vision.
Okay. If question from Arjun, if you have a lot of fragments between the access sheath and flexible scope, and you are not able to take out the flexible scope, what will you do? Tricky question. You have a lot of fragments between the access sheath and the flexible scope, and you are removing it. It is giving friction, like that. So if you pull, entire outer sheath can go off. So what will you do in such cases?
In that it is better to flush with the scope in situ, or you may go inside rather than coming out. Because what is happening is the stones are crushed across when you are coming out. So you need to push the scope inside. In that cases, you will be. That is the problem with the suction access sheath, because your outer layer of your scope, whatever the space is between the outer layer of your scope and the inner layer of your the ureteral access sheath. So sometimes it is possible that the fragments may damage your ureter scope.
I also have one suggestion, if you don't mind. In really lot of clogging with stones, take out entire system, scope, sheath all together out. And outside with syringe, you flush with lot of water, gently remove the, as you said, move forward and all the fragment out, and take out the entire system. Don't struggle to take out the flexible scope so that the outer sheath, people have shown entire outer sheath cast has gone out. So take along with the access sheath everything out. In case really if you try to over enthusiastically suck the fragments, ideally this suction is useful, as you said, the definition 200 micron or floating or aspiratable. So if you do proper dusting only, you should suck it. If you put in the mix of pieces and this thing, one piece can take out all the performance. One small piece, maybe 0.8 800 micron, can struck at the tip of the anywhere, and it will not allow the water to this thing. But as you said, last part, the dust which you have shown in the video, last video, in the pelvis, very fine dust is seen. That can be easily sucked out, I think. That can be easily sucked out.
That
Push
should
some
be the
water,
aim.
aspirate it. Push some water, aspirate it. That is a beautiful case. And the other one which you showed in the ureter first case, really useful it is. Otherwise, laser fiber here and there, you don't see it stop effect. You will touch the mucosa. That is a very, very useful case where, say, even with rigid ureteroscope, we do sometimes like that. We go inside, aspirate, and then restart when hydronephrotic system or completely obstructed system is present. But definitely there is role. Ultimately, last question, given choice, will you take a sheath with suction or scope with suction? Now,
I will go for a scope with the suction, because the sheath you require to have a separate devices for those. The cost involved is much. The chances of failure of getting the access to the desired level is always there. Your you will do RIRS only when your scope reaches the stone. So when you reach with the scope, you will be able to do a suction at that case. So my take will be MIST. Recently, I have been doing a primary RIRS without access seat. In those cases, it's really helpful.
Yeah.
Because
RIRS without, sorry to deviate the question, primary
Yes.
RIRS without access sheet, I have not done many. What are the difficulties you face, honestly? Primary RIRS without sheet?
primary RIRS is first thing is to engage into the ureteric orifice.
Okay.
With a long scope, it is very
Guide wire. Okay.
Yeah. Even with the guide wire, there is a lot of kinking is happening at the ureter pelvis because the angle of the ureter is sometimes very difficult to negotiate.
Yeah.
Second thing is we feel you can feel that the pelvic access system distension is more when the ureter access seat is not there.
Yes.
Ureter access seat will give some space to the fluid to come out. Without ureter access seat, sometimes the ureter gets. Second thing is the twisting moment.
Yes.
Sometimes there is a twisting moment of your scope. So your scope is fixed at the multiple areas. Like whenever the ureter is narrow at the ureteric orifices or sacroiliac joints or at the uretero-pelvic junction, multiple areas are where there when the scope doesn't move, your movement of the scope from the one calyx to another calyx is hampered when you're doing a primary RIRS without ureteral access seat.
Okay, you ultimately favor this.
Yes, I really miss sir. Manual intersection.
Very good. Manual, you say miss. Manual
Yes.
intersection scope.
Yes.
Okay, great. So direct and manual. Good names, miss, dis. Very nice. So nice, Parimal, and it is very innovative thing. These are going to change the management of the stones. Definitely suction will play a major role. A lot of people have already, Shah suction is used in PCNL in Indian instrument. Let's hope India also will come out with some suction device which easily can be done without much struggle or without much assistant help. So all the best, keep doing innovative things. Now you are at the fire and do that. Thank you very much.